Now we are coming to the wrap-up of the day, and we will go through the program of today and to see what was the highlight for each of us and underline what we have seen, what was interesting, and you can watch them online again and on demand anytime you want on the CIRSE website. I'm first turning to Stefan. Stefan, please, what was your highlight for today?
Yeah, Afshin, thank you. You might appreciate my personal highlight is the PAD Day, because the PAD Day, in my opinion, represents one of the real footsteps which we have set in interventional radiology with respect to peripheral endovascular therapy. And the frame was set with 2 focus sessions, one in the morning, one in the evening. One was dealing with CLI, dedicated imaging and diagnostic tools we have nowadays available, we should have available. And the other one in the afternoon has dealt with complex femoropopliteal lesion. What can we offer these severely diseased patients nowadays? What kind of armamentarium interventional radiology has to offer? But certainly another highlight is the controversy session on drug-based technologies. And you might imagine that we have to talk a lot about paclitaxel, doses, sirolimus. And I think it was very interesting to look at the poll before and after each presentation, the pro and con presentation. And I think it's worth, and I would recommend this to our audience and to all the CIRSE members, watch this on demand. It's really amazing. And last but not least, a real highlight is First at CIRSE. First at CIRSE represents the latest data which have been developed in the endovascular peripheral field and really presented first at CIRSE today. And we are proud that we had 3 presentations from the arterial field dealing with DCBs, stents, TACs, and another 3 presentations from the venous field, venous stents, the percutaneous creation of AV fistula, and so on. And parallel to this, some of these presentations are online in cardiovascular interventional radiology in our journal. And probably the last thing I would like to highlight was the Hot Topic Symposium. Myself was involved in that, and this topic was related to vessel preparation and showed once again nicely the armamentarium we have available. And one personal conclusion I have taken from this symposium is that high-quality balloon angioplasty is still of utmost importance.
Thank you, Stefan. One point I think you are absolutely right is the first on CIRSE is everybody's around to hear the last and fresh research group they are doing. If I'm asking you what you would like to see more for next year on the program, do you have any wish that you want to see more about?
My personal wish would be that probably the First at CIRSE Day could be enriched by more presentations, more first presentations at CIRSE, especially in the peripheral endovascular field. I think it is our duty to show that the broad field of interventional radiology, meaning interventional oncology, aortic stent grafting, and so on, but also the peripheral field. We have to be aware of the peripheral field because I would say interventional radiology started with the peripheral field. That was something which was really dominant, and we have to be aware that we are still in this business, and this is something we have to show up with in the conference.
Absolutely, I think you are right. Peripheral field is still there, and sometimes in many centers even growing again. That's what we are feeling in some centers, that there is a demand of this coming back. Do you feel the same?
Absolutely, especially as we have to deal with older patients, more severely diseased patients with respect, for example, to CLI, critical limb ischemia. I think these patient numbers are increasing, and it is our duty to offer them adequate therapy.
Thank you so much, Stefan, for your expertise. Thank you. We are lucky to have Laura with us. Laura, what you have seen as interesting and more reliable today, and what you have learned from today?
Thank you, Afshin. Actually, I took part in the thyroid ablation session, and as you know for sure, the number of thyroid patients that are referred to us are growing day by day. So there is a lot of interest in the field, and radiofrequency ablation can now be considered as the standard for ablation of benign nodules. But even microwave is starting to become more prominent with new devices, new antennas. So we are really willing to understand how this technology could apply to thyroid nodules. And in this year, we had the publication of the joint guidelines from the European Thyroid Association and CIRSE regarding the treatment, minimally invasive treatment in malignancies, both thyroid malignant nodules and recurrences. And really, again, I think this is one of the most exciting fields for us in the near future. We have now clear indications and recommendations, and together with the endocrinologists and also with the surgeons, we strongly believe that we can make the change for these patients.
I feel that endocrinologists are very open-minded toward us. Do you feel the same?
Yes, I feel the same, especially I have to say for malignancies. And even surgeons, they do not want to go on an operated neck twice. And this makes us really the game changers, yes.
And many diagnosticians, our colleagues are doing already the aspiration fine needle biopsy. I think this is a field they are mastering the technique of approach and guiding the needles inside any nodule. I think they should be more active to do such a procedure. What do you think?
Yes, well, I think that ablation is different, you know. Yeah. I do not want to be impolite with the diagnostics colleagues, but you have to be aware of the technology. And inside the technology, we have different devices. And each device has a different length of the active tip, can be unidirectional, can be radiofrequency or microwave. We even have electroporation, irreversible or reversible. So there is a world that is opening up. And why not? There is immunotherapy. The endocrinologist that deals with the thyroid tumors use immunotherapy a lot. So again, our role in exposing antigens may be very, appealing for the future.
I think you're right. Endocrine tumors are very, open for us for ablations. You're absolutely right. Have you seen something else you want to underline?
Well, I enjoyed very much the Meet the PI. I think this has been a great success in the past for CIRSE, and it will be in the future for CIRSE and also for ECIO, Philip. And I think that in this particular session, we had wide choice among cancers, from the kidney to the pancreas to the breast. So again, like David Breen concluded his presentation, this has been inspiring for the interventional radiologists to go to start studies, not to be shame or afraid to become a PI, and to look for industry support. So I think this was really a good session.
I think you're absolutely right. We were saying with Stefan, research is part of our job. As we said, research, education, and clinical work is essential to encourage our members to go for research and don't underestimate themselves that PI is something impossible to reach. We are all here, and we have a team in CIRSE for supporting research in this field. Thank you so much, Laura.
Thanks, Sachin.
Philip, again, coming back to you, about what you have seen interesting today and talking about what you were following today.
Yeah, I would like to highlight the session on ablation. And we are talking, also during the oral lecture, we are talking about treatment of HCC, that ablation is established, and so on. And we had the session focused on HCC larger than 3 centimeters with the question, is that the case for ablation? Is that the case for combined treatment? Is that the case for radioembolization, chemoembolization? And we have a great faculty, and I had the pleasure to co-moderate this session with a colleague from Laura, with Irene Bargellini. And I could make it short and say, okay, from 3 to 5, you have to combine chemo and embolization, and over 5, you have to perform something else, TACE or radioembolization. But the discussion was so active that if I make a short conclusion, it will never reflect the complexity of the question. Yeah? We talk also about liver function, what's the importance to look at liver function, etc. So nevertheless, the four colleagues who make the talk address first the multi-probe ablation, and of course, who can do bit better than Reto Ballet. The multi-probe application, the so-called stereotactic ablation of HCC. It's of course really effective, and he has a nice publication in Hepatology in the recent time. The second talk was focused on microwave ablation. Microwave is faster, is not easier, but faster, and induce larger lesion. It's probably, we know from the talk and we know from the literature that RF and microwave have similar result for HCC up to 3 centimeters. It seems to be that the fact that microwave is more effective for HCC larger than 3 centimeters. So, and the third talk from Tobias from Munich was, of course, combination. We are always talking about combined treatment, I believe, especially for HCC larger than 3 centimeters. Combining ablation, and I say ablation, I don't say RF or I don't say microwave, I say ablation, thermal ablation with chemoembolization. Is probably the solution. By the way, it is in the new guidelines, the new German guidelines, the combined therapy. You know?
I heard about one of your comments you were doing during this session. It was, if you are not used to a system or a ablation system, don't use it. If you are comfortable with something you are used to, continue to use it. I like this comment.
Thank you. Thank you. And by the way, that adds another factor, is the expertise. Who is performing ablation? My first comment was much more in the direction, if you know very well your radiofrequency device, you will be probably better than if you take a new device that you don't know. So your own expertise is really good. Yeah, maybe after it is a question of time, how many times you need. But to know his device and to know his capability and possibility is also one additional factor for that.
That's what you were telling, and I think the conclusion is really that every patient is different, and every patient should have his specific treatment. Means we cannot, as you said, tell more than 5 you do this, between 3 and 5 this. This is not a recipe like this. It's patient selection.
That's the reason I'm not afraid about radiomics and artificial intelligence and so on. There is, I believe, we still need many years, many decades to be replaced by artificial intelligence for that purpose, especially for HCC. Yeah, every case is different. Every patient is different. Every liver is different. Even in a liver, different metastases or different HCC are also different. So. Don't be afraid
of artificial intelligence.
We will keep it.
I love the remark of, I'm not afraid of artificial intelligence, I'm afraid of lack of intelligence. That's more about this, I think. This
but you are not talking about interventional radiologists.
No, exactly. Okay. Anything else to underline today?
Yeah, another point is this session that we maybe will be discussed in the future is, what about HCC larger than 5 centimeters? Should we abandon ablation? Of course, for this large HCC, we have to talk with our surgical colleagues. But more than 5 centimeters, we are moving in another, maybe more palliative situation with intra-arterial therapies. And it's, to be honest, it's not clear now. What do I do with an HCC that cannot be resected because it is larger than 5 centimeters, that cannot be resected? Chemoembolization, radioembolization, maybe combination of both, or combination with immunotherapy.
Yeah, large field for
research. I don't know.
Still.
It's for the next CIRSE. Or ECIO, of course, Laura.
A large field for research still.
Absolutely.
This is very interesting.
And it's really important.
Thank you so much, Philippe. And I will come to what I have seen, and I think is important, was Women in IR. The session was really, for me, eye-opening, how we can manage a partial time, how we can have a team which is stable, keep the people in the hospital, the best one, staying with us. That was really interesting. I think this is something, diversity, Women in IR is part of diversity, is essential. I encourage you to go on to see this on demand. Something else that I wanted to underline outside the on demand is, please go and visit our industry platform. They have invested a lot. The seminars are great, presented by many different presenters. Famous one, doing a lot of good work, and industry platform is interesting to see. Thank you so much, and see you tomorrow.